After all these great overviews of thrombolysis and endovascular therapies in ischemic stroke, this lecture will be about a very special subgroup of patients presenting to the ED, often those who are on DOACs and still are presenting with ischemic stroke. So as you all know, both the American and the European guidelines say that for someone who's taking a DOAC and who took the last pill in 48 hours, that's a contraindication for thrombolysis in general, unless you have a laboratory proof or a test that shows low anticoagulant activity. So the fact is that this exclusion criterion is not evidence-based, it was purely empirical when it was put into the guidelines. Obviously there are options to combat this, there are reversal therapy options, but anything that we do nowadays is mostly empirical. And the background and the importance of this is that actually about 15, 20 or even 25% of ischemic stroke patients in thrombolysis time window, they take DOACs based on literature evidence. So there are a couple of questions, like what is the reason, what is the cause of ischemic stroke in patients who are taking some kind of anticoagulants, or it should be a DOAC, actually the first point. Is there an increased risk, really an increased risk of symptomatic intracranial hemorrhage, intracerebral hemorrhage in DOAC patients after IVT? Does timing of DOAC, the last intake, really matter? And what's the difference between DOAC intake and DOAC effect? Because at the end of the day, we are more interested in DOAC effect in these patients and not the last time of intake. And what is the subgroup of these patients? Who should be candidates really for IVT? And should, if we do an IVT, should it be like empirical only? Should it be blind? Or should we guide or decision by some kind of assessment or tests? So this retrospective analysis of almost 800 ischemic stroke patients showed that they tried to find the cause of treatment failure. They only found some kind of cause in only 60% of cases, and actually the relative most cause was carotid atherosclerosis with hemodynamic significance. The relation to the last DOAC intake was could not be assessed pretty much because, and as we also experienced this in many of the cases in this study, 50% of the cases we did not know what the last time of intake was. And for those who were on DOACs, almost half of the patients were on full dose anticoagulation and about half were reduced dosing, either on label or for some kind of off-label cause. So this really tells us nowadays that we don't really know what's the actual background of this. And if we are about to do an IVT, perhaps we should assess the DOAC effect first. And I'm emphasizing DOAC effect and not the DOAC level in this case. So this study, this was a systematic review of 16 studies looking for bedside tests that could be used potentially for this particular management question. And they found a few blood-based DOCT tests and a few urine-based DOAC plasma level tests. Obviously, the urine dipsticks are only valid for exclusion. So when you don't see any DOAC level in a urine test, you can say that, okay, there is no DOAC most likely in the blood, but you cannot really say what is the level actually in the plasma. So there are a couple of blood-based options. I listed these three that this particular article found. And you can see that only they found one particular device, the blood probe, which had an assay specifically for all the four mostly used and currently available 10A inhibitors and direct thrombin inhibitor, that's ClotPro. The rest had limited availability. So, but what is ClotPro? And let's jump back a little bit to the opening session's topic, which was viscoelastometry. as you all heard, a great presentation from Dr. Fazekas. So that's a point-of-care method, and in Hungary, actually, during COVID, many of the emergency departments received the ClotPro device because there was a time when it was questioned whether you should thrombolyze COVID patients or not. And so ORED also has, and many of the EDs in Hungary also has the ClotPro device, but there are other thromboelastometric devices like TAG is what's available in the US mostly, I think, ROTAM, and some other which are currently under development. So at our ED in particular, ORED step performs this test. So we are able to get a result in about 10-15 minutes at the bedside from the time of blood draw. And what you can do is you can not only look at the clotting time and all the other like more conventional measurements, but with the specific assays that are available for TENA inhibitors and for direct thrombin inhibitor taking patients, you can actually get an information about whether these patients are having a DOAC effect at the time of measurement or not. So the bad news is that this only device, the ClotPro, which is the only viscoelastometry device currently that could do this, was bought by Haemonetics, the developer of TAG, and they just announced last year that they are discontinuing the supply of these tests. So currently, and this was a paper in the British Journal of Anesthesia, some physicians are and have been complaining about the fact that we in Hungary we still have a few of these tests, so we had a method to assess DOAC effect in patients, which is running out now, and we will not have these options in the future. So this is an unmet need, I have to say. And using these devices, so in Hungary, many of the places, many EDs and urology departments try to utilize this availability. So this group in the University of Pécs did this prospective observational study, which was allowed because their local protocol allowed to do thrombolysis in patients guided by thromboelastometry by ClotPro and see an efficacy or non-efficacy. And obviously this is a small cohort of patients. Only 15 patients out of the 40 were subtherapeutic based on the viscoelastometric measurements, and 7 received IVT, 8 patients received no IVT, and there was a trend towards a better outcome, but obviously there was not much statistical significance in this. But this just raises the question and the importance of this, that there should be further studies on this topic. So last year we started developing an interventional prospective trial plan in some ways called the TNK Budapest trial to actually address this question. While we were developing this protocol, we just learned that ClotPro will be discontinued. So now we are stuck here. So I really hope that there will be another device. And at the same time, if any of you is interested or would like to participate in developing the protocol, actually we would be very happy. Obviously, this should be eventually a multi-centric trial to get enough patients into that and to power the study enough. The idea is that we would do thrombolysis based on, or not do thrombolysis based on ClotPro, and we would do it with tenecteplase, obviously, because that's the future. Fortunately, in Hungary, it is not yet available. So this is all good if we measure, but do we have to measure at all? And that's also a current question, which also puts our trial plan in debate. So there is preclinical evidence that actually DOACs do not increase the hemorrhagic transformation compared to controls, and these are all animal studies yet, but you can see that these are from 10 years ago. And there are some observational studies. The biggest one you can see is from one from the USA, and the 2 others are international and not just multi-centric, but from different countries, and they all show the same trend and the same message that maybe there is no significantly increased risk of symptomatic intracerebral hemorrhage after IVT in these DOAC groups, which again is a huge question, like why is that? And we can go further. The last one from Meinelet and his partners showed that it was not significant though, but you can see that on the DOAC group, they actually had a lower occurrence of symptomatic ICH, which is kind of controversial and puts a lot of questions. So out of all these observational studies, a few meta-analyses were also were published recently, last year and 2 years ago. You can see that again in these meta-analyses there is no difference between the DOAC versus non-DOAC groups in terms of safety outcomes. So, but all this is observational yet, right? So where's an RCT on this topic? And there is an RCT on this topic currently. This is this DOAC trial, the DOAC intravenous thrombolysis trial and registry initiated by the University Hospital of Bern. This is a multicentric international trial. It's a prospective, randomized, double-blind. They aim to enroll more than 900 patients, and they would actually like to see what's the difference between the two groups, IVT versus non-IVT groups, amongst DOAC patients. So in summary, IVT seems to be safe in DOAC patients based on most recent evidence, but the first RCT is still ongoing, so we don't know this for sure. There's a question whether the timing of DOAC intake matters. These observational studies that I showed, they actually are suggesting that there is no difference, there is no effect of the timing of DOAC intake in terms of the safety outcomes, which is again quite interesting. And and obviously one of the most difficult group is those who you don't know when the DOAC was taken. And I personally believe that for this particular patient group, you need to have some sort of individualized management and assessment of anticoagulant effect in the first place. So we need a DOAC-specific, validated, bedside available hemostatic assay to provide individualized patient care. Thank you for your attention.